Moving ahead, we move on to the next topic. The next topic for the day is donors with comorbidities, which would be presented by Dr. Ram Mohan S. Bhat. And with us, we have the moderators for this topic as Dr. Deepak Kumar and Dr. Krishna Kumar from Bangalore. So without taking much time, I would hand over the session to our moderators, Dr. Deepak, sir, to introduce our speaker for the topic.
Yeah. Hello, everyone. Dr. Krishna Kishore is held up somewhere. So I'll introduce Dr. Ramon Sripad Bhat, who did his MBBS from Karnataka and went on to do his MD from Safdar Jung Medical College, Delhi. Later on moved to UK. He did his MRCP in internal medicine and nephrology. And he worked there and came back to India in 2011. And since then, he has been working at Narayana Health City. We all know his specialty of interest is interventional nephrology, but here today he's giving his talk on donors with comorbidities. Over to you, Dr. Ramon Bhat.
Thanks. Thanks for that kind introduction. Can everybody hear me?
Yeah.
Yeah. So without wasting any time, I'll just proceed. I would like to thank Emcure as well for giving me this opportunity, and NAC for also giving me the opportunity. So mine will not be as exciting as Anil's, and half as exciting as swap transplants. I've been given the mandate of talking about donors with comorbidities. So basically, I think it is about trying to expand the live donor pool. I'm not going to talk about cadaveric donors at all here. I'm just going to tell about what I think is the most common comorbidities encountered, the NOTTO guideline, what it says about what are the absolute and relative contraindications for a live donor, what do the Western guidelines say, and the most common comorbidities that we usually encounter, of which age I will probably leave it to Sanjay to talk. I think this talk also would have been quite aptly handled by Sanjay, because he's the one who does all these things. But anyway, I'm going to talk about donors with comorbidities, of which I think the most important one is diabetes. If we are able to include diabetics as part of our donor pool, we will be able to improve our donor pool by at least, I think, 30–40%. Others, I'm not so sure how much we can stretch in terms of, poorly controlled hypertension, cardiac disease, which is symptomatic, morbid obesity, or renal or urological issues, which actually should not be ignored at all. So, what does NOTTO say? NOTTO says absolute contraindications, anybody who is a minor, anybody who is young hypertensive, they say we should not consider, whether it's controlled or uncontrolled. Anybody who is more than 50 and on 3 or more drugs, anybody who is hypertensive and having end organ damage, anybody with diabetes, and also it says abnormal OGTT. It doesn't actually qualify exactly what it means by abnormal OGTT, whether it means only impaired fasting or both impaired fasting and 2-hour postprandial. Obesity is mentioned as an absolute contraindication, but then if you go to the relative contraindication on the right hand, it says obesity 30 to 35 is a relative contraindication. So I take it that they mean obesity more than 35 is an absolute contraindication. Any past history of thrombosis embolism, according to them, is absolute contraindication. Any coronary artery disease or symptomatic valvular heart disease is absolute contraindication. On the right side, you can see that it says that prior valve surgery, if it is done, I take it that prior valve surgery with now normal echocardiographic, features and good cardiorespiratory functional, testing, then probably we can consider. That's what they probably say. Peripheral vascular disease is considered as absolute contraindication, but if you see relative contraindication, it also mentions renovascular disease, which probably should be considered in the same category. Any chronic lung disease with hypoxemia, so somebody requiring oxygen or at rest, not symptomatic but hypoxemic, should not be considered for donation. So this would mean probably chronic smokers who have significant lung injury, or people who've had past history of bad tuberculosis and who have hypoxemia now. any recent cancer or those cancers with the long recurrence time, especially breast and all those things, it is considered as an absolute contraindication. Proteinuria more than 300, HIV, and psychiatric contraindications. It doesn't qualify what exactly it means by psychiatric contraindications. When we come to relative contraindications, these are the ones we always work with, and we stretch and we get them into the pool if possible. But then the absolute contraindications is one. In that, I think diabetes, hypertension, and obesity. These are the three major things where, if we are able to stretch a bit, we may be able to get in a few more donors into the pool. What does the AJKD core curriculum from 2018 say? Pretty much the same thing. So ones which are, got a A here, qualified by A, is a relative contraindication. So we are doing ABO incompatible. We are doing people who are highly sensitized. And then we are taking people who are having metabolic syndrome, people who've got HCV or HPV. We are taking them with a careful evaluation. But then it says anybody who's got a GFR of less than 80 should not be considered. Anybody who's got proteinuria more than 300 milligram per day should not be considered. Hematuria is considered as an exclusion criteria. Obviously, solitary you cannot. Anybody who's got uncontrolled blood pressure, sustained blood pressure more than 140 by 90, apparently should not be taken up for donation. And then anybody who's got diabetes, once again, should not be considered. Age as a barrier, I think I'll leave this to Sanjay, but just one slide. There is risk to the donor and risk to graft outcomes as well. There's studies, this particular study which I've quoted here has shown, comparable perioperative morbidity and mortality for elderly donors as well. It's a large cohort which has been looked at retrospectively. But they found that those who are older than 60, their mortality over a period of time is reduced as compared to the younger donor. But then when you compare it with similar people who have not donated, but who've got similar comorbidities, the mortality is comparable. When it comes to graft outcomes, you can see here they've compared live donors less than 60, that is their standard criteria donors, versus those who are older, versus those who would have stayed on the cadaveric transplant program and maybe opted for extended criteria donors because they want to have an earlier transplant, so they will opt for extended criteria donors. What it shows is people up to the age of about 65 or so, there is increased graft survival as compared to those who have donors who've got an age of more than 65. But then still, those who get a kidney from a live donor who's more than 70 years fare better than those who opt for extended criteria donor program. So definitely it is, having an older kidney is definitely better than having an extended criteria donor kidney, cadaver kidney. But this one doesn't compare with standard criteria cadaveric donor kidney. Just mention about age and GFR in the same breath as well. This is a criteria which has been mentioned in British Transplantation Society guidelines, which is what I use whenever I'm picking my donors. It gives you the age versus what is a cutoff. It doesn't just take 80 ml per minute as a cutoff for taking a donor for donation or not. So if you see, as a male, if you're about 65 or less, usually you should be having GFR of 80 or more. And then after above the age of 65, these are the criteria that the UK guidelines mention, and this is what I usually use, and I find it very useful. Coming to the most important things, impaired fasting and diabetes. Anybody who's got impaired fasting glucose by WHO guidelines 110 to 125, or anybody who's got a glycated hemoglobin between 6 and 6.5 should go on to have a 2-hour oral GTT, ideally, to clarify their status. And if they turn out to be having, just pre-diabetes, then you can calculate their risk of developing diabetes over the next 10 years by various models, which you can use to counsel the patient. Nowadays, most of us have started taking all these impaired fasting people because, if we try to, exclude them, then probably we'll be excluding a huge lot of people. A lot of our patients, when we are evaluating them, will have, a normal fasting and normal postprandial, but then glycated hemoglobin will come as, 6 or 5.9 or something like that, or 6.1. And then we are stuck. They've got a bit of obesity, but it's not too bad. It's 31, BMI of 31. They might be, smoking until quite recently. So multiple risk factors are there, and we are stuck. So, we'll have to work with these people, and unless we, include them, the prospective recipient is denied a better quality of life after donation. There's this study which most people quote, which looked at what happens if people who have got impaired fasting donate. So it's about 143 living kidney donors who received kidney from donors who had impaired fasting. They were followed up for a mean of about 10.4 years, and it was found that be it the renal function or proteinuria, both of them were similar at the end of 10 years, at the end of the first decade after donation. There was higher risk of the ones with impaired fasting going on to develop diabetes. 15.56% of those with impaired fasting developed diabetes at 10 years, whereas those who didn't have impaired fasting, only 2.2% developed diabetes over the next 10 years. But then the renal outcomes and mortality were same as people who were not having impaired fasting or not diabetic. Coming to diabetes, this one study which was published in 2010 in Transplantation from Japan. Japan has been pushing the boundaries with regards to live donation because they've got certain inhibitions for donation after death. So most of the transplants, 95% or even more than that of transplants are all live donor. And being a country where they've had nuclear families for at least 3 generations now, unlike us, where we are probably the first or the second generation who've had a nuclear family living. They have had hardly any donors in the family, so they have to push. So they have been at the forefront of ABO incompatible, at the forefront of using diabetic donors as donors. So they have looked at 444 live donors from a single center, where they had about 71 who had impaired oral GTT and 27 who were actually diabetic, and impaired fasting in only 44. So these people were compared with those who were having normal glucose tolerance, and they showed that outcomes after 20 years, not just a few years, after 20 years, renal outcomes and survival was the same in these patients who donated. What happens if somebody develops diabetes after donation? So, this is from US, looking at 4,000 odd donors, out of which 309, that is 7.7% of them, developed diabetes at a median time of 18 years post-donation. And these were followed up over a period of time, looking at risk of ESRD, risk of developing hypertension, risk of developing proteinuria, risk of developing hypertension and proteinuria. So all these risks you can see here, very, very small. So including risk of so the highest one is just developing diabetes, risk of developing risk of developing hypertension after developing diabetes was the highest in those who developed diabetes after donation. So most of them do quite well, even when they develop diabetes after donation. So that gives you confidence to take up patients who already have diabetes, as long as you qualify by looking at target organ damage and make sure that you carefully select the ones who might be at lesser risk. Look at and this is a statement, a guideline statement from BTS, which which is a surprise. A change for me. When I was there, we never even touched diabetics. And this statement from 2018, which is there in the BTS guidelines, it now says we have to consider diabetic patients as potential donors after careful evaluation of risks and benefits. In the absence of target organ damage and having ensured that other cardiovascular risk factors such as obesity, hypertension, or hyperlipidemia are optimally managed, diabetics can be considered for kidney transplantation after a thorough assessment of lifetime risk of cardiovascular and progressive renal disease. So I think this is where we should move globally as well, especially in India, where we are lagging behind in terms of cadaveric transplant, and then we have to increase our pool of live donor transplant. So that comes to that brings me to the next topic, which is hypertension. The NOTTO says anybody who is a young hypertensive should not be considered as a donor. However, most of the Western guidelines don't use age as a barrier. So anybody who's got uncontrolled hypertension, which is blood pressure more than 140/90, even on one or two drugs. So anybody who's got 3 or more drugs, should not be encouraged to donate. We can always encourage them to lose weight, stop smoking, all these things, lifestyle changes to control the blood pressure, and then we can get them to donate. But then when they're having uncontrolled diabetes, blood pressure, we should avoid the donation from these donors. And very specifically, BTS, which is not there in other guidelines, say that we should also use ambulatory blood pressure monitoring, and this is the cutoff that they use, 135/85, whereas American guidelines still maintains 140/90 even for ambulatory blood pressure monitoring for donor purposes. So I'll give you some information about ambulatory blood pressure monitoring in the next slide. So anybody who's got blood pressure, clinic blood pressure of more than 140/90 or ambulatory blood pressure of more than 135/85 on 3 or more drugs should not donate kidney. And anybody who's got end organ damage, retinopathy, LVH, proteinuria, previous cardiovascular disease are also not acceptable for donation purpose. And there is one good study which has shown that even those who've got a clinic blood pressure which is more than 140/90, when you actually do ambulatory blood pressure reading, almost 40%, 36.7% of them actually turn out to be having good control, or as having a normotension on ambulatory blood pressure reading. However, also there will be about 10% who will have masked hypertension. Those also you're going to pick up. So it's all about protecting the donor as well. Not only are we trying to improve the donor pool, we're also trying to educate the donor and protect the donor pool in terms of improving our outcomes for the donor and the recipient. I'll talk about cardiovascular disease as well here. Anybody who's got risk, having metabolic syndrome, borderline obese, maybe recently stopped smoking, mild hyperlipidemia, etc., definitely we'll have to look at their cardiovascular risk. But if they're able to achieve a METs of more than 4 on a treadmill test, BTS says we don't really have to launch into extensive tests. But then what they have done is they've included this calcium scoring as a new thing, where they say that if the calcium score is 0, then you can be very confident that that person has got very little risk of developing cardiovascular disease over the next 10 years or so. But all these things have to be done with the help of a cardiologist. And then we definitely have to not ignore the simple things like ECG. Make sure we are not missing out any pathological Q waves, LVH, left bundle branch block, atrial issues, etc. Obesity, I think all of us would agree, anybody who's got a BMI of 30 to 35 could be considered as a donor, but then with a lot of education, a trial of, loss of weight, etc., because the risk of perioperative complications for the patient is quite high in these patients. And for those who are having BMI of more than 35, BTS says they would discourage donation at all. But then certain guidelines would put them on hold, put them on a weight loss program, and including bariatric surgery. Certain centers would actively promote bariatric surgery in this lot, and then take them out for donation after a period of time. This would be my last slide, I suppose. I've just put everything else in one slide. Low GFR, I talked about it. Proteinuria more than 500, I would definitely not like to consider these people. We could, probably try and look at their, metabolic syndrome profile, get them to lose weight, after they've stopped smoking after 3 months, after they lose weight, after they control their blood pressure, we can probably reassess them, reassess their proteinuria. But then when they have that kind of proteinuria, I don't think we should be pushing them, trying to do biopsies or, to trying to justify donation. But definitely we should push for active investigation of mild persistent microscopic hematuria, which is, trace proteinuria, which would be 1.1 to 5 RBCs. Anything more than 10 RBCs would, most people, when you start investigating them thoroughly, they would get disqualified. But those with persistent microscopic hematuria, they might be having some, lower urinary tract issues. They might be having, thin basement membrane or something which will allow you to use them as a donor. Or it could be something like simple like a kidney stone. And then when it comes to stones, which is not very often, but at least in a year, you would get 1 or 2 patients who would be having a stone, odd stone here and there. If it's a small stone, single stone, you can transplant, leaving the stone in situ. If it is slightly bigger stone, there are 2 options. You can either put the patient through shortwave lithotripsy, clear the stone, and then transplant. Or then what many centers in the West are doing is they're doing ex vivo ureteroscopy to remove the stone on the table before they transplant. With regards to hepatitis B, C infection, I have not done any, and in fact, I sent one of my patients who wanted to have transplant from a hepatitis B donor who was a mother, but then who the gastroenterologist had actually cleared because the fibroscan was quite good, and HPV DNA levels were all quite undetectable. But our ethics committee had huge objections, so I had to send him to Columbia to have the transplant, and he had a very successful transplant. So it depends on assessment of the health of the liver and assessment of the activity of the viral infection. Because we've got good treatment for hepatitis C infection, we can treat the donor, assess the liver status, and then use them as donors. One more thing I've not mentioned here is what we find nowadays very commonly is fatty liver. At least about 10% of our patients who are coming for donation, even the thin ones, are having fatty liver, and that becomes a bit of a problem to whether to take them up for transplant at all or not. I don't know whether I have got one slide. No, I don't. So there is one study which I came across looking at 24 patients who had non-alcoholic fatty liver disease, who did donate, and then after 10 years, they were found to have no higher risk of progression of the fatty liver or any renal adverse outcomes after donation. That's my last slide. So I think the bottom line here is whether we can evaluate diabetics more thoroughly, including renal biopsy, apart from looking at their retina and their heart, to ensure that there is no target organ damage, and consider them for donation. Thank you.
Thank you, Dr. Rammohan Bhat. That was a lucid talk, and most of the comorbidities you have covered. I just had one question, since we're all interested to know about diabetics being donor, since we are moving into nuclear families and the options of donors being limited. Should we also consider age as one of the important factor when we choose these particular diabetics as a donor, when other things are okay, like retina is okay, no proteinuria? Should we give more emphasis to the age? What's your take on that?
So the risk score that I put there, I think will help us in counseling the patient. When it comes to that particular donor at that point in time, yes, we should consider age, but then I think we should consider the risk. Somebody who's got a risk of developing diabetes, the score, whatever I put, gives you the risk of developing diabetes in the next 10 years. Anybody who's got a risk of developing diabetes of more than 50% in the next 10 years, I think we should look at modifying whatever modified risk factors are there over the next 3 to 6 months, and then reconsider donation at that point in time, rather than just say that you're not a suitable donor at all. So that risk score does include age and all those factors. Family history as well, family history of diabetes and first degree relative, smoking, hypertension, use of statins, so which actually means whether you have got dyslipidemia. So that scoring includes all those things.
Okay.
Dr. Deepak, so I will add a few things into it. See, I do take in special circumstances patients who have well-controlled and recently detected diabetics. But my criteria, as you are putting upon the age as a factor to decide. So usually if the donor is above the age of 65, and he has a well-controlled diabetes with no target organ damages, and in situations where the recipient is in desperate need for a transplant. So in those situations, I consider. Now you will say, why you have taken 65 as a criteria? So it is very simple. See, if someone has a diabetes and renal, that is the kidney is normal, your proteinuria is not there, the evidence that there is involvement of the renal is totally not there. So normally from that day, for someone to develop the renal dysfunction or from that stage may take approximately 10 to 12 years, even if he is not controlling the sugars. So what is the average lifespan of expected in India? It's around 72 to 75 years. So 65, you add 10 years also, it is 75. So it is based on this theory that I put forward to the patient. And the fact that we do all related transplants only, and elderly donor, now it becomes, the recipient, they are more sensitive towards the parents or whoever has donated related in the family. So usually they come for follow-up with us only. So usually it doesn't happen that diabetes goes haywire. So based on these criteria, I take diabetics provided desperate situation for the recipient and age about 65 years.
Okay.
Yeah, I have similar points like Sanjay. Can you hear? Everyone can hear?
Yeah, I can hear you,
Yes.
Yeah, I think looking at now the younger recipients, especially they are in like 20s, 25, 30s, and then they're on dialysis for already 6 months, 1 year, and then they have a related donor, mostly parents. And then if they're newly detected diabetic, they're not diabetics before, but when they come for evaluation, I found that recently 3-4 donors, I found that there is diabetes. I'm basically impaired GTT, whatever it is, but they are diabetics. But if they have like parents and then the recipient is young and then there's no other donor, and then they can't afford ABO incompatible and they can't wait on cadaver transplant list for 3 years, I think that is where the NOTTO guidelines probably maybe after a few years they might change like British guidelines. So taking care of the donor's diabetes into consideration, if there is no target organ damage, absolutely, then probably we should accept to increase the donor pool. Otherwise, these younger patients living on dialysis for years, it is not possible. So probably where we have to judge and then risk of the patient having complications of diabetes, if they're 55 to 60, I would consider explaining the risk to the donor and the family, and then explaining the need for transplant for younger recipient. Yes, I'm going now that way, saying that some of the donors, I'm accepting, saying that explaining the risk to the donor as well as the patient family. If they're fine, then I'm going ahead with the further evaluation. That's what probably, because India is going to be critical of diabetes, and the donor 55 and all, you might see some diabetes. It's very difficult if there's no other donor, especially siblings and parents. Yes.
Ram, one question to you. With NOTTO recommendations stating that diabetes is an absolute contraindication, where do we stand medico-legally if something were to go wrong or the patient donor develops, let's say, ESRD in 5 years' time? I mean, what will happen in the court of law? The advocate may always show this NOTTO recommendation as an absolute contraindication, and would we have a strong case against us?
Yeah, I think I think it's a guideline. It is a recommendation. It is
it is a guideline.
You'll have to take a special consent form when you take such donors.
We'll have to counsel. We'll have to.
Because I have been taking people with hypertension for quite some time. I never rejected anybody with a single drug, and I was not taking diabetics till I joined Manipal. So they're a little more liberal on diabetes, with no end organ damage we were taking. And I think Sanjay's point is valid. If somebody who's 65 is mild diabetes, I think it's reasonable to take that compared to somebody who's 30 with diabetes wants to donate. So there's a difference. A father donating, 65-year-old father donating 35-year-old son. Maybe the story is different. So we'll have to. So, but this NOTTO guidelines, I think that is, as Ram Mohan Bhat said, it's only guidelines, not the law. But nevertheless, we should be careful because patients can use it against us if something goes wrong.
So to overcome that, whenever you are doing the affidavit, I think everyone who comes and signs in those affidavits, in everyone's affidavits, that line should be added on. Saying that all the risk patient is a diabetic because of the need for the recipient, it has been done, and the risk and the possibility of the renal failure later, which is very minimal, as been explained.
You need to have separate consent for that sort of extended donor. I think correct. I agree.
Yeah, and other thing what I'm doing now is, sir, apart from getting the affidavits done, affidavits is typed by a lawyer, and these fellows come and sign. So many of the times the relatives or the people who are related to them may go against you, saying
video
that you signed it. So what I am doing is I keep 20 rupees paper. So on the day, one day before the transplant, I make the donor and the recipient write in their own language all the risks involved, which includes even the risk of an expanded program. So they write in their language.
So in addition to the regular consent, which is printed, you take handwritten consent one day before.
Consent on a 20 rupee paper. Now they cannot.
Take it with some photograph also. That will be better.
Yeah, I think Sanjay's point is valid. Probably we should take this kind of consent when you're accepting a diabetic donor to considering the recipient is young and there's no other go to survive on dialysis for so long. And then probably in the video consent also we should record that this has been explained to the donor fairly well, and then evidence there also they sign the the register that they have been explained, and also they go to committee there also they question them. So probably we should explain options. However, the recipient interest consent apart from the regular
Just be on the side.
Any other questions?
Sir, there are some questions in the Q&A tab, sir. Would you like to take them, or would they be answered later?
We can take them now.
Dr. Ganesh Prasad has asked, mentally challenged donors recommended by a close relative, accepting by the hospital query. Dr. Ram.
So, our NOTTO, can you hear me?
Yeah.
So NOTTO doesn't give detailed explanation, but if you go through BTS guidelines and things like that, the risk has to be assessed by a psychiatrist. From a medical perspective, use of medicines which could have affected the renal function, like lithium and all those things, will be a issue for people with mental health disease. So we need to take a detailed history of.
But I think Ram is talking about mentally challenged donor. I think I have some experience in this. By and large, we will not take any related donors mentally challenged. Because that is not acceptable. But we have done only one case with a court order where the donor was mentally challenged. He was deaf and dumb. He couldn't give consent.
Yeah.
And so then we went to the court and got it done. But after that, we are not done. I don't think we should do also, because it's not, in my opinion, having done one case like that 25 years ago, I would not do it, because that will become the norm. Then people will start bringing mentally challenged relatives to donate. If there is a possibility of, I don't think it should be the norm, in my opinion. You should not do it.
I have got one experience, sir. I had one patient who was actually sister of a doctor, and mother needed the transplant. So they had got this child, and we evaluated the IQ. IQ was not very bad. They had reported it around 45. So apart from our, psychiatrist, we sent for the evaluation to a government center, that is to the Victoria Hospital. The psychiatrist was there and got the clearance from them. And then we submitted it to the state committee. So only our concern was, if the mother dies, then who will take care of the girl child? So on that pretext, only one such instance which I have done almost 10 years back, and both are doing fine now. The mother and the daughter both are, and the daughter is being taken care by the mother now.
Even our case was like that only, where the donor was donating to the only breadwinning member, the brother, and the judge also said, if the patient dies, the donor also will die because there's nobody else, and the donor's wife will, the patient's wife will throw out the donor first. So that is the reason the permission was given in the interest of the donor.
Okay. The other question was,
I have similar. One donor was there, I think brother somebody. So he came forward. He had some psychiatric, but he was pretty good. His IQ was good, and then he was done by two psychologists had assessed, and they were certified saying that he's understanding what exactly the problem, and then he can donate. But when he went to the committee they did not give the permission. So we said that, yeah, if the committee doesn't give permission, I can't do anything. Even the psychologist has given a certificate saying that he's understanding, he can capable of doing. But that family left, and he went to Hyderabad and he got transplanted. So it depends upon the committee also. Some of the committees are very strict. They follow as per their, I mean, they have their own ways of dealing. So I don't think every committee is same. So yes, some committees more liberal, and then they might give the permission. You are safe if they're given the permission. So we didn't do the transplant. He went to Hyderabad and got transplant. If there are no questions, any other questions, Deepak, from the audience?
From the audience, one more question is: can HIV positive donor donate to HIV positive recipient? That's asked by Dr. Ganesh Prasad.
I think it's cadaver donor, definitely.
Yes.
Yeah, even in live donation, HIV, if it is
acceptable,
undetectable load and good CD4 count, and if it is being donated to a HIV positive person, it should definitely be considered.
Okay. So if there are no further questions, we'll move on to the next talk.
Thank you, sir. Thank you, Dr. Deepak, for moderating it very nicely and taking up all the questions from the faculty. Just for the attendees, I would like to point it out that all these questions would be recorded and sent to the faculty members, and it can be also replied back to you in case we are not able to take them over an email. I hope that is fine with everyone.